Thank you, Renee. Appreciate those words. And we have a little more time. I know there's some folks are still trying to log in. The HUVA systems, there's a little learning curve. I sent out a message to the tech to see if they could do a mass email to those who are having issues logging in. It could be a little tricky. You know, one of the things, just as we're letting people in, as a substance use disorder treatment provider for adults, you know, some of the things with some questions that maybe throughout the day that we can think about is that before cannabis was legal, that there was issues with release of information from the dispensaries that were issuing out the medical marijuana cards. And that could be problematic when you're doing clinical staffings and wanting to understand the client and what their needs are, especially a lot that are within the judicial system that are able to get that, but you're wanting to, you know, work on, you know, update their treatment plan so it could be effective and not let cannabis get in the way of their treatment. So there could be controversy, but it's not a matter about the controversy. It's a matter of seeking clinical solutions to these issues of addiction. And there's a big difference. There's some people that can drink alcohol responsibly, and there's some people that cannot. And we believe the same thing applies with cannabis use. We're really excited. I'm hoping that we can get folks get in. We'll see if we could send some mass emails through HUVA to, you know, let people know that there's links. So with that, we're a little ahead, but we're going to go ahead and proceed forward. And I'm going to do my first introduction of, let's see here, the topic, the effects of cannabis and mental health by Dr. Martin Gonzales. Dr. Gonzales is the medical director for the Jail Diversion and Transition Services to the UNM Hospital Community Behavioral Health Department. In addition, he is an assistant professor of psychiatry with the University of New Mexico Health Service Science Center School of Medicine, Department of Psychiatry and Behavioral Science, who specializes in the treatment of severe mental illness and developmental intellectual disorders. Dr. Gonzales has experience in community psychiatry with extensive work alongside law enforcement, including Albuquerque Police Department's Crisis Intervention Team and the UNM Hospital Psychiatric Emergency Services. Dr. Gonzales is an active member of the UNM Department of Family and Community Medicine Transdisciplinary Evaluation and Support Clinic Project and Adult Special Needs Clinic, which focuses on adults with developmental disorders who have complex and medical psychiatric needs. Please help me. It's a privilege to introduce Dr. Martin Gonzales.
Good morning, everyone. I'm happy to be here, and I'm really excited to share the presentation I have for you all today and engage in what I hope is a very lively and interesting discussion. Hopefully this generates more discussion for everyone as you go out into your professional and personal arenas with more tools in your toolbox and support the people of New Mexico in the best way we can. So thank you for having me. And so I want to start this presentation with a preface that by no means is the information I'm providing today meant to be an extensive overview of cannabis or its interactions with psychiatric disorders. This is intended to be a primer and just kind of introduce some of these very complex topics and relationships between cannabis and how it affects the neurobiology of the human brain. This is a huge area with lots and lots of information and sometimes controversy and active areas of research. And so if you have questions throughout my talk today, please enter them in the chat, and then we have some time allotted at the end for discussion, and we can go into more detail if anyone needs clarification or has any questions. And so for starters, I have no disclosures and a review of today's objectives. And so to start, we're going to review the endocannabinoid system. We're also going to look to understand the effects and the relationship of cannabis in various psychiatric diagnoses. And then at the end, I like to close today's talk with some harm reduction strategies and ways to generate conversation with your clients, peers, patients, so they can use cannabis in a way that's not detrimental to their well-being. It doesn't exacerbate any of their underlying psychiatric or behavioral disorders. And so we start with the endocannabinoid system. And so the endocannabinoid system is a very complex system throughout the human body, and it serves as a neurotransmitter regulatory system. The first two primary cannabinoid receptors have been identified as the CB1 and CB2 receptors, where the CB1 receptor is found primarily in the central nervous system, particularly in the deeper brain structures. On this diagram, I've highlighted some of the structures here, including the basal ganglion, the cerebellum, which control movement and coordination, the hippocampus that's responsible for memory and the association cortices, and also all along the spinal cord and the peripheral nerves. When CB1 receptors are activated, these receptors inhibit the inhibition of dopamine release, resulting in the euphoric effects of intoxication, right? Dopamine is that feel-good chemical. And like many substances and substances of abuse, it causes a surge of dopamine, and cannabis is going to prevent that dopamine to some extent from being reuptake, and it causes more dopamine to kind of flood the brain. CB1 activation also cause inhibition of the release of neurotransmitters that regulate appetite, memory, pain, sleep, mood, and inflammation. And these may be the areas that are the targets of some of the medical aspects of cannabis that are still being actively researched. In the hippocampus, we see these regulations of memory, and this is thought to be why when actively intoxicated with cannabis, it impacts the ability to learn and retain information to some extent. Cerebellum and basal ganglia, some folks experience issues with coordination, initiation of movement, reduction of motivation. And then the cerebral cortex, that outer part of the brain with lots of indentations, and it's our gray matter. And this is where our executive function, our planning takes place, our sensations, our fine sensation takes place. Deeper in the brain is the hypothalamus. This may be the origin of like the munchies that we hear a lot about when people are using cannabis. It also, deeper to that is the dorsal vagal complex that regulates emesis and that nausea and vomiting response. And this may be the site of target when cannabis is used to reduce nausea and vomiting, especially in cancer patients. And then, of course, spinal cord, where CB1 receptors are going to participate in pain signaling from the other areas of the body up to the brain and out accordingly. CB2 cells or CB2 receptors are found primarily in cells of the immune system. And this is believed to be the area of inflammatory control, and where cannabinoids, both endogenous and exogenous, may have an effect on inflammation and regulation of the inflammatory process. And so cells of the immune system are primarily found in lymphoid tissues in our lymph nodes throughout the body's white blood cell surfaces. And this may be the reason why it has effects on pain and inflammation, as the white blood cell surface interacts with various cells throughout the body. And this is why it may reduce pain and alter the ability to feel pain because of this anti-inflammatory role of the CB2 receptor in the immune system. CB2 is also found in high concentrations in the spleen, which is a major immune organ, the GI tract, which the vast majority of our immune cells are located, the peripheral nervous system, and the testes. And this may be, at least theorized, the reason why there may be some impact in fertility in males because of the high concentration of CB2 in the reproductive organs. And so this is the diagram of the complex interactions of the endocannabinoid system at the nerve synapse. And so we have identified two molecules within this system. One is called anandamide, and the second is 2-AG. These are the first discovered and most studied of the endocannabinoids. And so if we look at this figure, endocannabinoids, the endocannabinoid system consists not only of the endocannabinoids, but also the cannabinoid receptors and the enzymes that regulate the formation and breakdown of these various molecules. Anandamide is described as the feel-good molecule, and it actually means bliss in ancient Sanskrit. And this was one of the first endocannabinoids that was ever identified. These chemicals, unlike other neurotransmitters, travel backwards across the synapse in order to regulate the release of other neurotransmitters. The endocannabinoids, endogenous endocannabinoids, meaning the ones that our own body produces, are produced on demand based on the response to any external and internal stimuli, and then they're broken down relatively rapidly. However, the enzymes that break down our own endogenous endocannabinoids, and endo means endogenous when it's combined like that, these do not participate in the metabolism of THC. And this is why we see the prolonged effects of THC when it's ingested or smoked. Cannabis also causes the activation and suppression of signaling at the CB1 receptor sites. And this is why we see such various effects of cannabis throughout the body. The overall goal of this system is to maintain homeostasis and manage stress. This is also the system that downregulates our fight or flight response and is responsible for the recovery phase by releasing anandamide. And so you're in an acute traumatic or stressful environment, your body releases lots of stress hormones, cortisol, epinephrine, all these things that get your body tense, your pupils dilated, your heart rate going. Once that stimuli is no longer in the environment, that threat is resolved, that calm down phase, that relaxation, the time it takes you to kind of recover from whatever stress or trauma you experience is a result of the endocannabinoid system doing its job and the release of anandamide throughout the system. And so this system is a major component in brain development and maturation as well, particularly in its role in regulating neurogenesis. And so that's the growth and the pruning of axon elongation, neural differentiation and migration. And these are our brain cells changed throughout the developmental period. Glia formation, how they join and stick together, and then the synaptic pruning, which particularly takes place during adolescence and early adulthood as our brain synapses solidify, and the ones that aren't necessarily vital to brain function are pruned away. And the endocannabinoid system changes over the lifespan. In adolescence, this system is at the highest levels because of the rapid brain changes that are going on. And this is why it's believed that using cannabis during this period can disrupt this development. And it can cause deficits in memory, deficits in learning. However, what we've learned is these deficits can be reversed, and someone can go back to baseline with sustained abstinence. And this is particularly important in individuals who have cannabis use disorder. However, recent research is revealing that some of these changes may actually be pre-existing prior to the initiation of cannabis use because of variable adverse childhood events that themselves increase the risk of cannabis use. And this is still being studied by the ABCD study, which is a multi-generational cohort study looking at children, following them throughout their lifespan, and just collecting all this data and analyzing it as it gets revealed. And so what's the relationship of cannabis and the endocannabinoid system? Well, we look at cannabis in and of itself, right? This plant contains over 400 compounds. 80 of them, 80 to 100 with the latest research, are known cannabinoids. The most famous and the one that's sought after for its intoxicating effects is delta-9 THC. But also important to that one is cannabidiol, which is a way to balance the effects of THC, and it does not produce the psychoactive effects. And so when we think about cannabis and its long history with humans, for thousands and thousands of years, this plant has been cultivated for a variety of reasons, for fiber, for seeds, for medicinal purposes. I remember my grandmother and her sisters growing this in their gardens with the other remedios, and just part of the herbal remedies that were used traditionally. Some of the first documented uses of cannabis can be traced to ancient Hindu texts, where it was taught that this plant was brought by the god Shiva for the pleasure of humanity. But its use, many anthropologists believe that the endocannabinoid system co-evolved with humanity's use of cannabis. In recent time, these compounds have been selectively bred by producers so that some strains now have almost all the CBD removed out, or vice versa, depending on the desired effects that they're looking to achieve. Compared to endogenous cannabinoids, which are short-acting, exogenous cannabinoids, both THC and CBD have longer-lasting effects on the receptors, thus causing the psychoactive effects. And this is why delta-9 THC in particular can alter brain development, in addition to having other effects at any age of use. And some of this is the goal, right? When someone wants to use cannabis and alter the sensorium, it can alter your reality testing, have impacts on reason. For some individuals, it can affect impulse control. It can affect the ability to set priorities and the ability to relate others, and it can also reduce motivation. So when we look at the epidemiology and the numbers across the board, this particular diagram looks at illicit drug use. And this diagram still classifies cannabis as an illicit drug across the past year for people aged 12 and over. And so cannabis is the #1 used illicit drug across the world, particularly in the Western world. When we look at the numbers, just a little over 7.5% of adolescents aged 12 to 17 actively use cannabis. A little under 20% of adults 18 to 25 are actively using, and just a little under 7% of adults older than 26 use cannabis. And that's data that's a little old, and so those numbers have changed somewhat since then. When we look at past use in the last month of all substances across the board, and this is also including alcohol and tobacco, cannabis is third to alcohol and tobacco. And what I found interesting in this diagram is 60% of folks are actively using a substance of one type or another in the past month. Humans like to alter the reality. And even tobacco, nicotine in and of itself is a mind-altering compound just from the physiological effects that happens. And so deeper questions as to why this is part of human behavior, and that's a topic far too broad for today's discussion. And so when we look at the trends, this is data from last collected in 2018, past year of initiates among people age 12 and older that are using cannabis. And this is always the fear we hear from the political side. You legalize cannabis and it's going to be the Wild West, and every kid from here to wherever is going to be using cannabis, and that actually panned out not to be true. When we look at the adolescent ages 12 to 25, their initiation into cannabis use has remained relatively stable, especially as legalization is continuing across the country. With regulation and legalization, there are more barriers for adolescents. There are some that theorize that as their parents use cannabis, there's not so much of a mystery to it. It's not so rebellious to use cannabis anymore, so that's less enticing as well. What we are noticing is the initiation of cannabis use in adults over 26 as the legal status is changing throughout the country. This is particularly concerning in regards to behavioral and mental health, because this is the age range, early to mid-20s, where severe mental illness like schizophrenia and bipolar first presents, when individuals have their first break psychotic episodes or their manic episodes. And we'll talk a little bit about that relationship and how it pertains to cannabis use. And so cannabis use in psychiatric symptoms. This is a challenge in a lot of ways, because many psychiatric disorders do not fully present until either late adolescence and early adulthood, while simultaneously these individuals very frequently are first using cannabis during these time periods. What we have learned through the research is folks with severe mental illness and concurrent cannabis use do have poor outcomes, lower educational attainment, higher rates of unemployment, an escalation of substance use, and more severe and more frequent episodes of psychiatric symptoms in the acute phase. However, ongoing use does not necessarily lead on to a substance use disorders. Just like was mentioned earlier, many individuals can use, much like alcohol, can use cannabis recreationally, enjoy its effects, use it in moderation, and it really doesn't have a negative impact on their life. But for some individuals, use gets extremely reinforced in, like other substances, in the mesolimbic and dopamine system. This is that reward regulation system in the deep brain, where 90% of those with cannabis dependence or cannabis use disorder also have at least one lifetime episode of co-occurring mental illness. And this is theorized to be also a abnormal regulation of that dopamine system in the mesolimbic cortices of the brain. But causality is not clear, and it's difficult to generalize that if cannabis use in and of itself causes mental illness, or if mental illness increases the risk of cannabis use. And this is still an area of research that's being looked at. And when we talk about poor outcomes, we also have to take in mind that cannabis use in and of itself is not a risk factor. And we also have to take this in the context of the larger social determinants of health, socioeconomic status, adverse childhood events, trauma, whatever the case may be. There's other factors that relate into this kind of complex dynamic. And so there is, at this time, there's no clear connection with cannabis use and the increased risk, particularly for suicide or violence. And that's always a heated discussion as well. As more people use cannabis, are more people going to become psychotic and violent or commit suicide and all these kinds of things? Some studies have found an increased rate of suicidal ideations, with the particularly elevated risk of suicide attempts in heavy users, but these findings have not been consistent from one study to another, and there's other co-founding factors and biases in these studies. The violence associated with cannabis use has been attributed largely to the illicit nature of obtaining it through the black market. This risk is nullified once the cannabis is being obtained on the legal and regulated market. And so there is no correlation or relationship between cannabis use and violence or acts of violence in and of themselves. So what are the neurocognitive concerns about cannabis use? It's altering our sensorium. It affects the developmental stages of adolescence and early adulthood. And so some long-term longitudinal studies have shown that chronic heavy use can reduce IQ points somewhat, independent of other co-founders. The deficits can also be observed in decreased processing speed, impairments in attention and working memory. It can also impact executive functioning. That's our ability to plan, our ability to maintain sustained attention. And just like I mentioned before, impulse control and decision-making can be impacted, particularly while acutely intoxicated. Perceptual disturbances are common, including slowed perception of time, abnormal reality testing, or even frank hallucinations and illusions in some individuals. Many describe increased focus with loss of global awareness. So you're kind of fixated on one thing without being aware of what's going on around you. Some animal models have revealed that when CB1 receptors of the anterior cingulate gyrus are activated, there's a reduction in motivation. This is a controversial theory and it's still being looked at. Again, findings have not been consistent from one study to another. But this may be the mechanism that people describe being stuck, couch locked, that, sitting for periods of time, losing track of time. But this is still an active area of research. One study did explore the cognitive effects of children. This is part of that ABCD study I mentioned earlier. The effects of children who had secondhand cannabis exposure. And this is particularly, I think, a valid topic because many adults are using cannabis in their homes around their children. And it compared that to the cognitive effects of children exposed to secondhand tobacco smoke. The notable finding in this one, which I thought was particularly interesting, is those children who were exposed to secondhand cannabis smoke actually had overall better reading skills compared to secondhand tobacco exposure, where those children had higher rates of deficits in visual spatial memory, deficits in visual spatial skills, and deficits in language skills. This is still preliminary data, and these findings have not been replicated. Also, some animal studies have found that when exposed to higher concentrations of cannabis, there's a reduction in the physical effort to obtain high value rewards with preference for small and immediate rewards. This is believed due to the reduced transmission of dopamine in the central striatum, deep structure of the brain. But this is similar to other substances of abuse. And so it's unclear if cannabis in and of itself affects motivation, or substances of abuse across the board have this effect. And so there's no way to confidently state that this is true for cannabis in and of itself, and this still has to be fleshed out further through more research. So the big one everyone is worried about, psychosis. Psychosis is a complex phenomenon where it can occur in a wide variety of conditions, both medical and psychiatric illnesses. It can present in delirium, in depression, co-occurring with mania. We can see it in individuals with dementia. We can see psychotic experiences in those with vitamin deficiencies, brain masses and lesions and tumors, toxicities to various chemicals and substances. And these are all independent risk factors for psychosis. When we look at cannabis and its relation, we're starting to recognize a dose response curve in some studies, as where cannabis use alone increases the risk of developing psychosis by 4 times as the dose increases and the frequency of use increases. But it's important to note that a brief psychotic episode or a substance-induced psychotic episode is very different from the phenomenon of schizophrenia, and schizophrenia as a disorder in and of itself. And so this leads us to schizophrenia. And so there's a lot of research going into schizophrenia. And one of the new things we're recognizing about this disorder is now it's starting to be considered as a neurodevelopmental disorder, where the symptoms of schizophrenia in the prodromal period are being identified in the adolescent and early developmental period, even before frank psychosis first occurs in early adulthood. The current evidence suggests that the effect of cannabis on symptoms of schizophrenia is due to the increased density of CB1 receptors in the central nervous system. This has been identified in post-mortem samples in individuals who have a previous diagnosis of schizophrenia. And the highest concentrations of these CB1 receptors are found in the prefrontal and posterior cingulate cortices. And so these are the areas of our higher brain functions. There are also some genetic correlates that we have identified where there are polymorphisms in various genes that encode for the components of the endocannabinoid that are altered in individuals with schizophrenia. Another interesting finding is that anandamide, this feel-good endocannabinoid that binds to CB1 and CB2 receptors, actually occurs in increased concentrations in individuals with schizophrenia. And one theory is postulating that this chemical in and of itself may actually be protective against psychotic symptoms. Now, when we look at cannabis in its role with individuals with schizophrenia, THC competitively binds to the same receptors as anandamide. And so its effects are similar to the transient symptoms of schizophrenia because it binds so tightly. And this is where we see the increased paranoia, the grandiosity, the disorganization, the perceptual disturbances, hallucinations, the blunting of the affect, and looking relatively fat, and the emotional and cognitive changes that at baseline occur as the spectrum of the schizophrenia symptoms and then exacerbated by cannabis use. Cannabis use is associated with an earlier age of onset of the psychotic episodes, not necessarily the prodrome, but that, again, that's still being studied. The earlier age of onset has not been consistent. And we have not seen, as cannabis use increase, we have not seen higher rates of schizophrenia. Globally, schizophrenia occurs at a little under 1% of general population. And as that general population is using cannabis, the thought and the fear among many professionals was the rates of schizophrenia are going to follow in kind. And this actually panned out not to be true. However, those with more risk factors, including family or personal histories of psychosis, any indication of prodromal symptoms, these individuals should be educated and encouraged to avoid cannabis altogether, just because they are higher risk for negative outcomes. Having more severe symptoms, individuals who have schizophrenia and also use cannabis tend to have higher rates of medication non-adherence and higher rates of rehospitalizations for acute psychotic decompensation. Much like the cognitive effects of cannabis, when these individuals maintain extended periods of abstinence, they revert back to their baseline level of functioning, have higher symptom reduction rates, their severity of symptoms go down, and their outcomes tend to be much better. And so then we look at substance-induced psychotic disorders. And so these have to occur with the simultaneously or within close proximity of using a substance. And so we'll see hallucinations, delusions, negative symptoms, that social withdrawal, isolation, disorganization, kind of bizarre and erratic behavior, but this is due to the substance, and it can cause distress to the individual or those around them. Keep in mind that hallucinations that are recognized by the individual as not being real is actually more consistent with the perceptual disturbance and not necessarily a psychotic experience. And that's kind of the goal when using an illicit substance. You want to change your reality around you. Some of these psychotic symptoms may persist for several weeks after last use. And this isn't only true with cannabis. This is true with other substances that can cause psychotic experiences, various hallucinogens, methamphetamine, those kinds of things. And so in the clinical setting, it's important to distinguish substance-induced psychosis from a primary psychotic disorder. And this can be difficult, especially in the acute setting. And so what we need is time, where symptoms of psychosis can persist or recur in the setting of continued abstinence from the substance. Then this is more consistent with a primary psychotic disorder. Those individuals who have a underlying primary psychotic disorder and then use cannabis may also have a substance-induced either exacerbation of that psychosis or a separate substance-induced psychotic disorder where their symptoms may not be consistent with their chronic or recurrent symptoms. This relationship is thought, particularly in the current market, is thought to be related to the high potency of THC and in various cannabis products out in the market or when used in larger quantities. Some studies have found that CBD may have some antipsychotic properties that we mentioned earlier, and that the earlier age of onset and heavy use has been associated again with those poor outcomes, precipitating that first break psychotic episode in those with elevated risk. And in general, those with a primary psychotic disorder, schizophrenia, schizoaffective disorder, and the like, tend to have higher rates of cannabis use and substance use in general compared to the population across the board. Many postulate that the motivations for use in this population are to relieve dysphoria. Antipsychotic medications have horrible side effects. They block what we call blunting of the hedonic drive. Because antipsychotics block the release of dopamine, dopamine's that feel-good chemical, many individuals with schizophrenia describe the world as being more gray, less pleasurable, feeling numb, feeling like a zombie when they're taking medications. And so they often use substances to help relieve that dysphoria. There's also a social component to it, and particularly with cannabis, it's a very pro-social, much like alcohol substance use. And so they want to fit in. They just want to, be one of the party or enhance their experiences. And that's more of a recreational kind of experience. Or individuals often have co-occurring or comorbid psychiatric disorders or medical reasons that they may be using cannabis for these purposes as well. Next, we'll look at mood disorders. And so bipolar in particular, much like schizophrenia, cannabis tends to have a negative relationship, and this can exacerbate the symptoms of mania or precipitate manic episodes, particularly in those individuals who are not adherent to their medication. Individuals with bipolar 1 tend to have more frequent manic episodes when using cannabis on a regular basis, get hospitalized at higher rates, and tend to have higher rates of suicide attempts. Again, just like we saw with schizophrenia and the cognitive effects, prolonged abstinence for those individuals who have bipolar 1 and abstain from cannabis, especially if they have an underlying cannabis use disorder, revert back to baseline and have similar clinical and functional outcomes compared to those who have never used. Now we look at depression, where regular and heavy cannabis use has been found to increase the risk of developing a depressive episode, but the causal link has not been determined. And this is the chicken and egg question. Do people use cannabis and then get depressed, or do they get depressed and then use cannabis to try to alleviate some of those symptoms? What we have recognized is the risk of developing depression, or at least one depressive episode, does increase across the lifespan if someone begins using cannabis in the adolescent period, and this may be due to the altered brain development that occurs during this time. Anxiety. This is a big one and a very complex relationship in regards to cannabis use. Many individuals report that there is a subjective reduction in their level of anxiety with cannabis use. And some studies have supported this compared to placebo, but these studies are small, have lots of confounders, and are at risk for bias. Some individuals have recognized that THC in higher concentrations can precipitate fear, panic, and brief episodes of extreme anxiety, especially in individuals who are non-habitual or newly initiated to cannabis and don't really recognize what their threshold or what their limit is and what their body's able to withstand. There's also a relationship between the THC and CBD ratios and how that can impact anxiety. High THC to CBD has been found to have increased rates of anxiety, and vice versa, where there's a low THC to CBD ratio, these tend to have a more opposite effect or an anxiolytic effect. fMRI studies have shown that when an individual is presented with a fearful stimuli, CBD acts on various brain regions. In particular, again, that anterior and posterior cingulate gyrus, the amygdala, that fear control center, and our prefrontal subcortical pathways to ameliorate some of that anxiety and provide a calming effect. But this isn't true for everyone, and it's hard to generalize because there are heterogeneous effects of cannabis, because the endocannabinoid system is so prominent throughout the body, where many folks can experience relaxation, euphoria, heightened perception, while others with the same strain of cannabis can experience anxiety and dysphoria, disturbing perceptual disturbances. And this is because of the blockade and the activation of various receptor sites within the endocannabinoid system. Another hot topic and controversial topic is PTSD, where there's a growing number of anecdotal reports that individuals use this substance to ameliorate and reduce the symptoms of PTSD. Unfortunately, there is no strong evidence that cannabis is effective in treating PTSD in and of itself. Cannabis, much like benzodiazepines, Valium, Xanax, Klonopin, can blunt the symptoms of PTSD, but cannot effectively treat it to resolution. The only evidence-based treatment is trauma-informed psychotherapy, EMDR and the like, to treat PTSD into remission. However, the relationship of cannabis and PTSD is not necessarily clear and still being researched actively. What we have learned is the concurrent use of cannabis in the setting of PTSD in many individuals, not all, has been shown to increase the risk of memory impairment, poor attention, poor concentration, and impaired information processing, and can actually impact the effects of trauma-informed psychotherapy. And so many therapists encourage individuals not to be actively intoxicated with cannabis during the treatment sessions. Those with PTSD across the board have increased rates of substance use in general, in particular alcohol use, and have higher rates of alcohol use disorder. And this goes back to the possible self-medicating theory and in effect to reduce the very distressing and disturbing symptoms of PTSD. Next one is sleep-wake disorders. And so cannabis can give the impression for some individuals of ineffective sleep. Despite having minimal overnight awakenings, especially in recreational users, while medical users, on the other hand, may actually have reduced sleep disturbances and report a subjective improved quality of sleep. What we have learned from various sleep studies is that cannabis can interfere and reduce REM sleep, that restful rapid eye movement sleep phase. It can cause shorter onset of sleep latency and longer stage 4 sleep, and that's the later stage of the sleep cycles. Heavy users in particular, especially when they're discontinuing use as part of the withdrawal syndrome, report higher rates of sleep disturbances, poor sleep, or anxious sleep at night. My particular area of interest is neurodevelopmental disorders. These can be particularly difficult to treat because behavioral symptoms can occur frequently, particularly aggression, where we see that in about 3/4 of children and adolescents with autism spectrum disorder, and 1/4 of those who carry this diagnosis will also engage in some type of self-injurious behavior, and these are difficult to manage. Other symptoms that we can see is irritability, agitation, or aggression and assaultive behavior. A lot of these individuals come to psychiatric clinics to help reduce the severity and frequency of these symptoms. But medications can only provide so much benefit, and there is a significant risk of side effects. Metabolic syndrome, movement disorders, spasm disorders, serotonin syndromes. These individuals tend to have paradoxical reactions or the opposite reaction of medication intended effects. So this results in polypharmacy and multiple medication changes, which are very common in clinical practice for these individuals. And so many advocates, patients, caregivers are asking, can cannabis be an alternative for these individuals? And we'll talk a little bit more about that in just a sec. One interesting neurodevelopmental disorder is ADD and ADHD, where the diagnosis in and of itself during childhood does increase the risk for developing substance use in general, most commonly alcohol and cannabis. The inattentive type of ADD, ADHD tends to be associated with increased severity of substance use. Excuse me. While hyperactive and impulsive type tends to be associated with earlier age of first use, just as an artifact of this neurodevelopmental disorder. Little research, unfortunately, has been done to explore the long-term effects of cannabis use in those individuals with ADD and ADHD. When we look at prenatal exposure to cannabis, and we're seeing this in growing rates, as many mothers will use cannabis to help alleviate the symptoms of morning sickness and the nausea and vomiting and those kinds of things. We'll get off psychiatric medications to try to alleviate anxiety or pain syndromes and get off opioid medications. And so many researchers are looking into the prenatal effects. What we have learned thus far is that prenatal exposure to cannabis does not necessarily cause cognitive deficits in the children, but these children tend to have higher rates in deficits in attention and patterns of externalization behavior consistent with ADD, ADHD diagnoses. This same cohort that is being looked at in the ABCD study have also been found to have higher rates of psychotic-like experiences, seeing shadows, hearing voices that aren't necessarily true hallucinations and more consistent with illusions or illusionary type experiences. And so then going back to the neurodevelopmental disorders. And so there's a growing number of caregiver reports, case reports, that they're seeing improved behavioral symptoms with cannabis use in various neurodevelopmental disorders, autism spectrum disorders. However, there's little research to support this for lots of reasons, ethical reasons. We can't do randomized control trials in this population because they can't consent and those kinds of things. But some of the reported behavioral improvements with cannabis use in this population, they've seen less anxiety, less anxious agitation, and a reduction of medication, and in particular antipsychotic medication. This is believed to be secondary to the properties of CBD rather than THC, because in lab models, it actually reduces the activity of brain cells and may be the pathway to reduce excessive neuronal activity, particularly in autism spectrum disorder, that is believed to cause some of these challenging behaviors. And the current research is looking at high dose CBD and how it impacts these individuals. And so what are the evidence-based medical uses? And so there is good evidence and FDA approval for cannabis derivatives and synthetic cannabinoids, notably Marinol or I can never pronounce this right, Drobanol, Marinol. And so these indications are for nausea, vomiting, and pain in individuals with terminal cancer. And then in children with specific type of seizure disorders. And in this population, it has to be high dose pure CBD, and not all seizure disorders. There's a subtype of seizure disorders that this is particularly useful for. Epidiolex is currently being researched as a pharmaceutical grade of CBD, a CBD derivative that's being studied not only in these children that have seizure disorders, but also being studied in children and adolescents with autism spectrum disorder. Unfortunately, many of the indications in state medical marijuana programs, and these are long, extensive lists, are not the result of peer-reviewed scientific data. These indications have been put on these programs as the result of activism, patient advocacy groups. And this is unfortunate because it's hard to make evidence-based clinical recommendations despite these indications being on medical cannabis programs. But because of the legal status of cannabis in the United States is the primary barrier to doing good quality research. that'll allow us and give us the information to make evidence-based and clinical recommendations for these individuals. Evidence has shown that regular and heavy use can exacerbate mood and anxiety symptoms and psychotic symptoms, but there is no strong evidence for effective use of cannabis in any psychiatric condition. Some of this is for the lack of research, not to say that there may be some evidence down the road, but currently there is no FDA or scientific evidence-based research supporting its use to treat any psychiatric condition to date. One new development that is coming out is that anandamide, when isolated, may have pharmaceutical potential to treat cannabis use disorder and may actually reduce the severity and frequency of withdrawal symptoms associated with cannabis cessation. So now, how do we talk to our clients about harm reduction? And how do we educate them to incorporate cannabis into their life in their meaningful way, however they choose, so it doesn't have such negative impacts on their well-being, their outcomes, and their mental health? And so first things first, know your strain. Are you using a sativa? Are you using an indica? Are you using a hybrid? And what's the difference? And so our sativas, right? These tend to be more uplifting, energy-producing strains of cannabis. People describe them as having a cerebral or more of a head high, a spacey effect. And these are best recommended for daytime use. Unfortunately, these also have a high THC to CBD ratio, particularly in the current market where CBD is almost bred out entirely, and we're seeing 95+% concentration of THC in these strains. And so these ones, for individuals that already have pre-existing anxiety, paranoia, psychosis, should be educated to avoid these strains because they can exacerbate these underlying symptoms. It can also cause palpitations, and some research is revealing that individuals who have underlying cardiac conditions can actually have exacerbations of the cardiac symptoms when using cannabis in various concentrations. And so then we look at indicas. And so these tend to be more relaxing, more calming, have more of a body systemic effect. And so these ones are often recommended for nighttime use, relaxation use. The benefit of an indica versus a sativa is these tend to have higher CBD to THC ratios. And so for my patients who want to incorporate cannabis, either recreation or medically, I educate them to choose the indica or indica dominant hybrids. And what a hybrid is, it's a crossbreed between a sativa strain and an indica strain to create a unique strain in and of itself, depending on the properties. Plant genetics are very easy to manipulate, and so you can selectively breed your various cannabis strains to get various flavor profiles, effect profiles, and the like. And so again, encourage your clients to use indica or indica dominant hybrids to avoid exacerbating their underlying psychiatric symptoms. And so more tips. Again, back to CBD to THC. For those individuals with psychotic histories, prodromal histories, I encourage them to use CBD only or extremely high CBD to THC ratios. CBD tends to have the more medical potential and reduces the risk of adverse reactions to THC. Also, in preventative measures for adolescents or individuals prone to psychosis, have family histories of psychosis, the conversations I have are quite frank, and I discourage them using cannabis, alcohol, or any other substance of abuse or intoxication that can alter their sensorium or their neurochemistry, because it increases the risk across the board of decompensation. Also keep in mind that, and we see this a lot, especially when Colorado first went legal and folks were going from New Mexico to Colorado and obtaining cannabis products and bringing them back to the state. Recognize the delayed effects of edible versus smoked cannabis, right? Where edible products can have a delayed effect up to an hour, if not longer, after ingestion, because it has to be metabolized through the GI tract, absorbed into the bloodstream, and then transferred all over the body. Versus inhalation, when you smoke it, it goes right into the arterial system and immediately into the brain after that. And so what a lot of new users, especially new users to edible formulations, don't recognize is if you eat a piece of candy or chocolate and you don't feel the effects in 10 or 15 minutes, you need to wait another 20, 30 minutes, because the more you use, you're going to get an additive effect. And the cumulative doses, because of the affinity of these compounds to the CB1, CB2 receptors, can be quite intense. And so often we'll have new users of cannabis who came in distress, anxious, even hallucinating, because they ate a whole 400 milligram candy bar in one setting. And so how do we treat that? We, calm, quiet environment, low dose benzodiazepine, and just let the body do its thing and metabolize the cannabis. Also hydrocarbon compounds, especially in individuals with pre-existing pulmonary disease, have a family history in pulmonary disease, because you're putting flame to an organic material and releasing hydrocarbons, this can exacerbate underlying pulmonary disease. And so these individuals should be encouraged to use either edible, topical, or tincture formulations to avoid exacerbating their lung disease or resulting asthma attacks and those kinds of things. And so that's where we're at. So those are my references, and let's open it up for questions and discussion. Let me stop this share screen here.
Thank you, Dr. Gonzales, for this great presentation. Just a couple of announcements in between. One, we're running ahead of time, which is a good thing. We'll assess the time during these questions if we're going to move to either take a break early or take a break for lunch early. So we'll kind of look at the consensus of the team. So just FYI, the video is being recorded, as you've seen, and it'll be available on Whova for up to 3 months. Also, we'll be talking with the speakers for their PowerPoint presentation, if they allow to share that, if it's not proprietary. So I know there was a question. I think this is a great information. And starting off with our first question, Dr. Gonzales, and Amanda, you could help me out here when she gets back. And I think Josh is going to help decipher. So the first question, please discuss amotivational syndrome in the content of THC substance use disorder.
Sure. And this is still an area of active research. And so the initial theory was that cannabis use in and of itself causes amotivational syndrome. It destroys your motivation. You're lazy. You're at the whole stoner kind of stereotype that everyone thinks about. What we're learning is this isn't necessarily true for everyone. In the acute phase of cannabis use, there is a blunting of motivation. It's kind of the desired effect, but we do not see this sustained in the vast majority of users once the intoxicating effects are alleviated. What we are learning is the amotivational syndrome is pretty consistent across all substance use disorders as an effect of the altered dopamine regulatory system. And so it's still being flushed out, and a new study just got published that specifically states that cannabis does not impact motivation in a negative way. And this is more consistent with substance use disorders, because that lack of motivation, that altered executive planning and executive function may predispose individuals to a substance use disorder at large, and then exacerbates that lack of motivation, where cannabis in and of itself does not cause that for long-term effects for the vast majority of users.
Thank you. And there's a couple of other questions around PTSD. In terms of the realistic, before cannabis was legalized, a lot of the dispensaries were, 20, 25, 26, 27, people hit the criteria to be eligible for the medical marijuana card. PTSD we see in the SUD treatment a lot. In terms of diagnosis, how does a dispensary or a nurse or a prescriber, how is a diagnosis easy to get, or how does that work in terms of diagnosis?
It depends who you're going through, right? And so if you're going to go through your mental health professional, the DSM has criteria to diagnose someone with PTSD. The traumatic experience, either directly or indirectly, sleep disturbances, mood disturbances, flashbacks, reliving, avoidance, all those kinds of things have to be there to diagnose PTSD. Unfortunately, many of the cannabis medical cannabis providers that have set up shops around town for profit. You give them, $100 or something, they'll do an assessment. A lot of these individuals, you tell them, I had a traumatic childhood, they'll diagnose you with PTSD, you go next door and you get your cannabis. And so that's a for-profit kind of business model. Me personally, I think is unethical because they don't recognize the negative effects of cannabis on various individuals, and that diagnosis requires more nuance, and particularly how it's going to be treated. And they don't educate these individuals on how cannabis doesn't necessarily treat PTSD, it just may blunt the symptoms. And it actually discourages people because of the false perception that cannabis is going to treat their PTSD into remission. They tend to avoid psychotherapy because it's difficult and it's painful and it involves reliving trauma over and over and over again. And so that education component we need to work on.
Excellent, thank you. Because when somebody is referred to adult, to a substance use disorder treatment program, and they're on cannabis, it's under the marijuana medical card. It's very, there's problems in how to treat them because of, one end, they shouldn't be coming in stoned to a therapy session, individual or group. But even with the release of information and communicating to really create an effective treatment plan, there's not that communication. Do you see if there could be laws or anything that could change that to streamline this system, with these the dispensaries that are, some of them are just money motivated, and they could care less about the folks with addiction issues.
Right. If we could find a way, and again, there may be some legal hurdles to go through this, but if we could create a system much like the PMP, where in the medical, right, only for medical users, the purchases are tracked, they have a certain amount of units that they're allowed to use. The dispensaries keep track of the sales with these individuals. If we could create a statewide database or a regional database, much like the prescription monitoring program for controlled substances, this will allow prescribers to monitor how often someone's purchasing cannabis, and then we can incorporate any amount of data that we want. And so I think just overcoming those legal battles and then developing the programs and the software or incorporating it into the PNP in some way, I think could be a good way to partner with the dispensaries and track this from a clinical standpoint.
All right, thank you, Dr. Gonzales. Another one, could you elaborate more on the effects of cannabis on treating PTSD? I was under the impression that it was highly effective.
I see, and that's the false narrative that's going around in the community. And so PTSD has intense symptoms, right? The anxiety, the fear, all these kinds of things. And so cannabis works the same way as benzodiazepines do in PTSD. It blunts the symptoms, but over the long term, it does not treat PTSD into remission. And much like benzodiazepines, and for a long time, folks would use Xanax and Klonopin, Valium with the diagnosis of PTSD to function in society, but those in and of themselves have their inherent risks. From a risk-benefit perspective, I think cannabis is safer to use than benzodiazepines, but cannabis does not treat. And so we got to think about symptom relief versus treatment to remission. So cannabis will provide symptom relief. It will not treat PTSD into remission. Trauma-informed psychotherapy is the only evidence-based treatment model available. And then if an individual is high while they're undergoing psychotherapy, the effects of that psychotherapy tend to be blunted because of the cognitive effects of cannabis and the impact of learning and memory.
Thank you, Dr. Gonzales. Ashley Anhuba asked, what is your opinion on autism and cannabis use on children?
And so that's a very controversial topic. And so I think it's important to have a very frank and kind of well-balanced conversation. There are lots of legal barriers to that. And so that is, I think, a deeper conversation. From a lot of the case reports that are coming out, that CBD in particular, is showing some promise to treat the symptoms, the behavioral symptoms of autism spectrum disorder. We have to recognize that autism cannot be cured. This is a neurodevelopmental disorder. This is a lifelong disorder, and we have to think of treating autism not to remission, not to cure, but improving quality of life. And folks on the autism spectrum are going to have to deal with these symptoms and learn how to socialize and incorporate these symptoms for the entirety of their life, unlike depression, anxiety, PTSD, which can be treated to remission. And so we need to think about autism very different than PTSD, where we're looking at symptom reduction, where they're engaging in self-injurious behavior, they're agitated, aggressive. CBD, high dose CBD is looking like it may be a promising treatment modality. I don't treat children in particular in my clinic. I work with adults with neurodevelopmental disorders, and the families who are able to provide this for their patients, in many, not all, but many, have seen some significant improvement in the quality of life by reducing the symptom severity and frequency. Now, the DD waiver for adults, again, in particular, has a lot of limitations. And so like DD waiver group homes and caregivers cannot provide cannabis to an individual client. This has to be provided by family members because of the federal regulations that come around it and inability to control and regulate it from that end. And so I'm anxiously awaiting the data from the research of Epidiolex and how its effects are on children on the autism spectrum in helping regulate some of their behaviors.
Thank you, Dr. Gonzales. And again, looking at the time, we got plenty of time, so please send in your questions in the chat. Next question by Larry Herrera, and I'm gonna try to pronounce these words, my apologies. What can you share on cannabinoid hyperemesis syndrome? Did I say that right?
Cannabinoid hyperemesis syndrome.
Thank you.
We'll call it CHS. And so this is a very rare syndrome, and for a long time it was thought to actually be a psychological syndrome. We're actually learning that's actually not the case. And so cannabis is frequently used to ameliorate the symptoms of nausea and vomiting. Has, like we talked about, Marinol has an FDA approval to treat nausea and vomiting in individuals with terminal cancer and the like. In some individuals, there may be an abnormal functional level in the dorsal vagal complex in the brainstem. And this is a very old brain region, deep where the brain joins the spinal cord that regulates these kinds of very primitive physiological processes. And these individuals where the regulation is altered, when they ingest cannabis, it causes intense nausea and then even vomiting. Interesting enough, the effective treatment for this is a hot shower. Again, it stimulates that area of the brain from the external stimuli and reduces the effects of nausea and vomiting. These individuals should be educated to avoid cannabis for themselves because they're having a negative reaction to it, because their brain chemistry is just a little different than the typical population.
Thank you. Next question. Let's see. How damaging can the profit diagnosis be to a person's future?
I think that depends on the person and the diagnosis. And so if someone has severe mental illness and have very intense symptoms, I think this can be very detrimental to that particular patient's outcome and result in more frequent hospitalizations and a decline in their overall level of functioning. For other individuals, it kind of depends on that one person. Many of my patients have openly admitted that they will, before legalization, will seek a medical cannabis card just to avoid the legal consequences from illicit cannabis use. And so they'll describe some traumatic experience to one of these for-profit clinics, get the card, and it protects them from legal consequences. That may be a benefit, particularly folks that have, legal issues, on probation, on parole. From a harm reduction strategy, that's not so detrimental. For the entrepreneur, I mean, it's great for them. They're making tons of money off of this, but ethically, they have to wrestle with that on their own.
Got it. Thank you. Let's see here. How successful is psychotherapy in treating PTSD? Does success of remission depend on the level of trauma? Therefore, perhaps treatment of symptoms with cannabis use may be the best option? Question mark.
Right. And so it depends on the individual. And so psychotherapy, again, when we look at the evidence, trauma-informed psychotherapy has the best outcomes. When we say the best outcomes, what do we compare that to? A quarter of the people, maybe. Some studies, 50% of people who engage in this therapy achieve remission. There's not a lot of incentive to engage in PTSD psychotherapy because it involves reliving the trauma, and that's painful. And you know, humans are adverse to these kinds of experiences. Also, individuals that don't have the cognitive ability to be psychologically minded, to engage in self-reflection, engage in these kind of psychotherapeutic exercises, don't necessarily benefit from psychotherapy in that regard. And so those folks may actually get more benefit from just blunting the symptoms of PTSD, but they have to recognize that the PTSD is not going to be cured. We're just controlling symptoms at that point. And that's a risk benefits conversation to have with every individual. The nature of the trauma doesn't really have an impact. And so what can be a very traumatic experience. And so part of our training in psychiatry, we do a lot of work at the VA with combat veterans, and where you get two veterans of the same unit experience the same horrific traumatic experience. One has no symptoms of PTSD, one has crippling symptoms of PTSD. It's just how their brain integrates that information, processes it, and then how they alleviate it. Individuals that have higher risks for PTSD, some of the initial studies are exploring the theory that the CB1 and CB2 receptor systems may be abnormal or function differently in these individuals, where the anandamide that we talked about earlier that reduce the fight or flight symptoms may not be occurring in high enough concentrations in those folks that are higher risk for PTSD or develop PTSD. And so anandamide in and of itself may be a treatment option for those individuals. Again, this is still an area of research, and it's difficult to do these types of research in the United States because we can't do randomized control trials with cannabis. And so this is why I advocate for getting it off of the scheduling system, so we can do good quality science, and where we shouldn't be making our recommendations based on personal experiences and anecdote. We need to make our recommendations based on scientific, cold, unemotional scientific data.
Thank you, Dr. Gonzales. And when doing screening for a substance use disorder treatment program, when you're administering a cannabis use disorder screening tool for a diagnosis, a lot of times in rural and frontier areas where there's lack of resource in terms of access to psych evals and so forth, right? We just don't have access for this type of evaluations. But when you're administering a cannabis use disorder screening tool, can you talk a little bit about that and the effectiveness of this? Because when it gets into harm reduction with people with addiction, the controversy gets abstinence versus harm reduction, but kind of getting to, you know, does this person have a CUD issue going on? I see.
And so, like all substance use disorders, we're looking for impacts on quality of life. And so just kind of think about it in that regard. Can someone have a opiate use disorder and still recreationally use cannabis? Yeah, they can. And so we look at their cannabis, and like all substance use disorders, is there escalating use in amount and frequency? Is there tolerance being developed, and so they're having to use higher and higher concentrations? Is it impacting their quality of life and their ability to engage in their day-to-day activities, hold down a job, engage with their family, meet the responsibilities from one day to the next? If cannabis is having a negative impact on that, that in and of itself is a use disorder. And so that has to be addressed. And so abstinence only for cannabis use, alcohol use, opiate, meth is proven to be ineffective. And so it's all about harm reduction, slowly changing lifestyle and making lifestyle modifications and finding other things that can fill the void that cannabis is filling for that particular individual through various supports, meaningful activities, and the like. But from my experience and my recommendations is always take a harm reduction approach, because if you come at someone with an abstinence only approach, by and large, you're going to turn that person off to treatment in general, and they're going to be less receptive to having that conversation that their cannabis use has now entered a disordered phase.
Got it. And I really believe educating, as you're mentioning, with the old school abstinence-based treatment programs, and it could be controversial, but at the end, it's confusing to the client. So I hope I'm not repeating. This is by Myra Mandel. Do you foresee cannabis being used as a type of MATS, medication-assisted treatment for opiate use disorder?
Potentially, many of my colleagues in the addiction world have started asking that same question, because many of our patients that have opiate use disorder developed it as a result of prescription opioids. They had a horrible accident, prescribed, 300 Vicodin that they could use at their discretion, and then it just escalates from there. And so because of the anti-inflammatory and the pain regulatory properties of the endocannabinoid system, I think the potential is there. Again, we have to deal with the legal hurdles so we can study this in a meaningful way to see if it's actually a valid treatment option.
Got it. Thank you. Deborah Newman, if you could restate your question, because it was associated with one before directly, please. Going down, does cannabis use blunt the effectiveness of EMDR therapy in addressing trauma and post-traumatic stress?
Yes, it does. And so this is why we encourage folks not to be actively intoxicated on cannabis or a benzodiazepine when engaging in EMDR.
Excellent. Thank you. Good question. Let's see if I can do this. I have a client that has an opiate use disorder in early remission, but occasionally overly relies on benzos to reduce their anxiety. For harm reduction purposes, I consider recommending medical cannabis use. Does this sound beneficial or dangerous?
From a harm reduction standpoint, I would recommend it actually as a beneficial intervention because of the addictive potential of benzodiazepines. And unlike opiate withdrawal, benzodiazepine withdrawal can be fatal. And so we don't want them going from opiate dependence to benzodiazepine dependence and then have to taper off the benzodiazepines, or if they don't have access to it, suddenly go into acute withdrawal, have a seizure and die. And so if they're going to be using benzodiazepines to reduce their anxiety and prefer to use cannabis, educate them on the types of cannabis, right? Indicas, indica dominance, about the delayed response of edibles and things like that, and to use it truly like a medicine, right? Dose it throughout the day. Where I have, I oversee various CSWs who work with individuals on the medical cannabis program. And I encourage them to approach this like a trip to the pharmacy, right? They need to recognize the amount of cannabis that they find beneficial, how they dose it throughout the day. We don't want them to be high all day, every day, because that's not therapeutic. And then that's going to result potentially in another substance use disorder. And so if we use it truly like a medicine, dosed appropriately in appropriate intervals, it can be a safer alternative than benzodiazepines for controlling anxiety if the appropriate strain is identified with particularly high concentrations of CBD.
Excellent. In your presentation, this is from Miranda. In your presentation, you said that cannabis does not help bipolar disorder. However, is it possible that it can help some bipolar symptoms?
And so in regards to mania and psychosis, cannabis absolutely makes these worse. And so, right, that's the diagnostic criteria for bipolar 1 is someone has to have a manic episode at least once in their lifetime, resulting in hospitalization. And so what we have learned is cannabis use can precipitate a manic episode, it can prolong a manic episode, and can exacerbate or increase the risk of developing concurrent psychosis when manic. It can also exacerbate the symptoms of depression and anxiety when someone's on the opposite end of that bipolar spectrum. Some folks with bipolar also have co-occurring anxiety and may use cannabis to alleviate that anxiety. And those individuals should be educated, again, to use very low concentrations of THC relative to CBD because of the risk of exacerbating the more severe symptoms of their bipolar disorder.
Thank you. Let's see here. I think it's Danica Chavez. most of the research that you currently use, is it from other countries and their research? What data do you currently use?
And so the data I get, what's available publicly on PubMed, open source sites. And so the APA journal publishes quite a large body of research. There's good research coming out of Israel that's actually quite promising, and actually is recognizing a lot of the medical benefits that cannabis may have. NORML, the National Organization for the Reformation of Marijuana Laws, has an open library of research on their website. Not all of that research is peer reviewed to the same level, and so you have to read that very critically. But yeah, I try to find research from around the world because it's so difficult to get high quality research in the United States.
Thank you. Let's see here, Sylvia Marcus. Do you know if those who prescribe medical cannabis screen their clients for a cannabis use disorder?
I would hope so. I would hope so. Many of the for-profit shops, based on what my patients tell me, they do not. They do not. It's like a simple form you fill out, and they're basically rubber stamping these things. In a more traditional kind of mental health setting, a good clinician should be screening for all types of substance use disorders. And also, I want to clarify some of that language a little bit. Cannabis cannot be prescribed. It can only be recommended. And so the form we fill out is not a prescription because it's not an FDA approved medication. And so we can recommend the use of cannabis. That gets submitted to the state reviews it, and then approves or denies the medical cannabis card. Got
it. What is your experience of once somebody is diagnosed, if you will, with a cannabis use disorder? A lot in the intensive outpatient or residential treatment, higher level of care. Have you seen any, for an example, the most popular one, I believe, in the state of New Mexico for adult intensive outpatient is the Matrix model, right? Either by SAMHSA or Hazelton. Are you familiar with any CUD, cannabis use disorder curriculums, and then also to directly treat it? There's a lot of poly users that we know, but do you have any, have you researched or seen the administration of an evidence-based modality related to cannabis use disorder?
Not at the moment. The most common use is, or modality is the typical kind of NA group therapy models, harm reduction approaches, reducing the amount and frequency of use. Things like bupropion have been explored, gabapentin have been explored as medication-assisted treatment with variable results that haven't been consistent. I'm hopeful that the new research in anandamide might be a promising avenue for medication-assisted treatment in cannabis use disorder. But because cannabis use disorder, when we look across the spectrum of cannabis users, is actually pretty rare. For cannabis in and of itself, in isolation. In poly users, we see that in higher rates. And the focus tends to be on the more harmful substances, right? The opium, the opiates, the methamphetamine, the alcohol, where cannabis use is kind of given lower priority. And so there's not really kind of a solidified curriculum, at least not to my knowledge at this point, but I don't treat addictions on a regular basis.
Thank you. So I challenge all participants in the HUVA that HUVA is going to be for networking and communication for the next 3 months, that if you find any cannabis use disorder screening tool that you may want to share it. Also, if there's any links or information on curriculum that to incorporate into your treatment program. So that's just something to think about, that now we're seeking solutions clinically to treat those individuals. Another common thing within the court systems, when you have non-clinical people making suggestions and recommendation that somebody should try cannabis to help them with their problems. And I know I'm answering my own question, but I tell people and professionals to be cautious that, not to make those recommendations, that, it's kind of like Russian roulette or gambling. Dr. Gonzales, of non-clinical people making recommendation that somebody try cannabis to treat their problems or whatever conditions they have.
Right. That's a tough one. My personal and professional thought is stay in your lane. Don't make clinical recommendations if you're not a clinician. From a liability standpoint, if someone makes a clinical recommendation and they don't have that medical background or at least a clinical background, they're putting themselves at risk to carry that liability if there's a negative outcome or a bad consequence of that recommendation. I would prefer that they recommend that individual seek the counseling of a clinician and follow their recommendations as appropriate for their treatment. They shouldn't be making generalizations. Unfortunately, with cannabis, the perception is it's either poison or panacea, and it's neither. And the conversation should be more nuanced than that.
Thank you. Priscilla stated, when treating schizophrenia, what are your thoughts on the difference between the two types of medical cannabis, i.e. THC or CBD, and could it cause more psychotic incidences?
And so for individuals with schizophrenia, schizoaffect, or any history of psychotic experiences or disorders, I recommend that they avoid THC entirely. THC can precipitate psychotic episodes, flare up their psychotic symptoms, and make them more refractory to medication. If they're going to use cannabis medicinally, I encourage them to use CBD-only formulations. Often, we're learning that this is the compound that reduces anxiety. This is the compound that helps reduce inflammation and pain and all those kinds of things. And so anyone who has any kind of psychotic history, they should avoid THC if at all possible.
Thank you. And Amanda, I'm going to have you look at this last question to help me out. Those are, I don't want to slaughter them and get Dr.
Okay, I'll try.
confused.
Research in anandamide using an exogenous or synthetic anandamide.
And so the initial research is using natural occurring anandamide from animal models. And so it's still theoretical at this point. I'm sure some pharmaceutical company will try to make a synthetic derivative and put it out to market if it does show promise. But the initial research is looking at natural anandamide.
Got it. Any more questions? We're ahead of the time in terms of, we were going to, the presentation was going to end, I believe, at 10 o'clock with questions and answers from 10 to 10:30. We are ahead of schedule, so I'm thinking maybe we'll give it a couple more seconds for any more questions, and then we may break a little early. We'll break early and start early, and that'll give us a little longer for our lunch break.